नमस्कार दोस्तों, good evening, salam, sat shri akal. How are you all? Friends, Dr. Seema Pandey's talk show with our knowledge shots with V4 is once again with you. Today, we are going to talk something very, very unique and special, which every possible obstetrician, especially infertility specialist, is always in dilemma what to do, what to advise, and how to do it. And that is genetics and infertility, or the correlation, or how to do it. To talk about this matter, today we have our expert, Dr. Veronica Arora from Sri Gangaram Hospital. Welcome, Veronica, on board. Before I go further, I would like Dr. Veronica to introduce herself to our viewers.
Hi, good evening, everyone. Wish you all a happy new year. So, I am an obstetrician and a geneticist. I am working as a clinical geneticist at Sir Gangaram Hospital, and I am very happy to be a part of this program. And every time Seema ma'am does something, it's always great. So, let's hope to learn from each other.
So, friends, and there are many people, in fact, a school of thought who think that infertility is a genetic disease. That is called genetic basis of infertility. And according to them, the couples who are self-fertile, that is nature's way of preventing bad genes from propagating to the next generation. And many of us, we do witness it, especially with the obstetricians and gynecologists and infertility specialists, as nature plays its own ways in many of our cases, where we look at the beautiful embryos and wonderful lining with good blood flow, and this pregnancy does this implantation does not take place, or a fetus where you've got the you did everything right, but at around 6 to 7 weeks it just does not go further. So the if we look at those things and looking at the limitation of the science today, we can say yes, this could be the genetic basis of infertility, and nature is trying to do that genetic engineering, which we the human beings are trying to over to just bypass it, or go we are trying to go overboard board. So here I would like you to introduce to our my friends and my co-moderator, Dr. Anuradha Khar from Bangalore, Karnataka, Dr. Arshi Iqbal from Kota, Dr. Rajlakshmi Valavalkar from Thana, Mumbai. So Dr. Veronica, are you there?
Yes,
Yes.
absolutely.
Yes. So, Veronica, like in your day-to-day practice, you've been doing both the roles. You are playing as obstetrician, as a geneticist. What is your experience? Like, are you feeling that these genetic factors they have increased in number, or our awareness has risen about those factors, and people are they coming to you in more numbers? Are you getting more tests to perform some genetic testing over a couple, over a baby, or in utero fetus?
Absolutely. I think that there has been a large increase in the number of couples who are now attending the genetic clinics. And there are many factors for the same. Of course, the number one factor is that we are now doing these programs. Were we doing these programs 10 years later? No. 10 years earlier. So we weren't. And all these awareness campaigns and awareness programs helps not only the general public but also the doctors to know that every primary or a secondary infertility where we do not find the uterine related or a fallopian tube related causes is not idiopathic. There are genetic factors which may cause this. So, due to the increasing awareness and knowledge of the obstetricians, we now have increased referrals. And the second important factor is the decreasing cost of the genetic tests. Earlier, even those obstetricians who knew that there were these genetic tests available were not confident in referring because of the very high costing that was there in the genetic test. So now, with the lower cost, more and more people are affording for these tests, and that's why we now can test and we now see more patients with these disorders.
Yes, you are really, really absolutely correct in this way. Like earlier, when you used to come for sending your concept is for genetic testing, that is a very simplest example I can give. Even myself, I used to think, what is it going to change? Is it going to change the prognosis of the patient? Is it going to help me in treating this couple? So, and because of the cost factor involved, we were really, really reluctant in sending these genetic materials for testing. But nowadays, like, things have just gone in opposite way. As per newer guidelines, as Veronica can just highlight, that the testing of this conceptus for genetic abnormality is the first and foremost test before testing the couple, and we used to do it the other way round. Am I right, Veronica?
Yes, yes, ma'am, absolutely. So now, if couples come to us with recurrent pregnancy losses and you have a conceptuous, the best test that you can perform is actually on the affected person, that is conceptuous in this case. So we do a test for ruling out aneuploidies and as well as deletions and duplications. So we do a test on the conceptuous, which is known as chromosomal microarray. So today the test cost has come down by a lot, and the test would cost anywhere around 8 to 10,000, and more people are getting these tests done. So once you know that the conceptuous had a particular abnormality, you will be more confident in counseling the couple. Okay, so this happened to your baby, and we will make sure that this does not happen, or we will reduce the chances of the recurrence.
Yeah. I basically want to add something here. So when we talk about testing the conceptus, the question arises, when do you send people for this test? And that is what So if somebody has had one miscarriage, then obviously it is not indicated. Guidelines are very clear on that. So if you go the American way, they would generally tend to send after two miscarriages.
Yes.
So two miscarriages, third time a woman miscarries, then it is like recommend within their guideline to send the the product of conception for testing. If you go the European way, normally it is advisable after three miscarriages.
Yes.
So the latest guidelines are actually they haven't put down their foot on whether to put send after two or three. They say you try and take a look at the entire picture and then decide depending upon whatever your local trends are. So in India, I know there are certain centers that will wait for three miscarriages to happen, and there are certain centers which will send after two miscarriages. There is no right or wrong there. So the timing is something that I wanted to add in.
So what is
I
said
think the
Gangaram?
sending of
Yes, ma'am. So I think more universally in India we are testing at two, and defining it by two recurrent losses, and of course ectopic we are not including in that.
Yes.
Yeah, but I have a question, Veronica, that I think
Yes, ma'am.
age should be an important factor to be considered. Like, do we wait for two or three miscarriages to happen in a, say, 38-year-old or 39-year-old, where the reproductive her own this thing is on the decline? So I think it should be
Ma'am,
age
so
based
yes, ma'am.
rather than
That
giving
is
a
absolutely
proper.
true. Yeah. Yeah, that is absolutely true. But that being said, at second miscarriage, we are always testing. So that is one definition we are following. So one miscarriage is so common. We know that so many of the pregnancies spontaneously miscarry. So testing at one is still a little challenging. But of course, if someone wants to, then we cannot deny the testing. So we can always tell a person who's 40 years or 39 years of age who's had a miscarriage that this is the pro and this is a con for testing. So, but
So
it is not a mandatory recommendation in such a case.
So,
So any
Veronica, I
couple where there is no abortion history and the patient is on a higher side, suppose 38, 39, they can voluntarily go for testing or not.
So, if there is no history of abortion, so we are only looking at a advanced maternal age. So, the disorders which are related to advanced maternal age include the Down syndrome, Edward Patau, and certain trisomies. So, these trisomies we can test after pregnancy. It is not like we are doing something to prevent them. The other thing is, if they're undergoing IVF, then they definitely should undergo PGTA along with it if there is advanced maternal
But
age.
counseling should be done for all these couples.
Yes, definitely that you would need testing later.
So, Dr.
I would,
Veronica,
I,
yeah, yeah, please go ahead.
Yes, ma'am.
Seema, can I? Okay.
Yeah, yeah,
So,
please go ahead.
so Veronica, let's come to infertility per se, because our topic is genetics and infertility. Of course, it encompasses a lot of disorders. So, around 50% of infertility cases are due to genetic disorders, defects, we know that. And those gene defects could be single, multiple. Everyone knows that. Now, I want to ask you specifically, what are the disorders we should look for in a male, male infertility per se? Say a patient is azoospermic. What
Yes.
are we doing in those cases?
Yes. So I think the first thing is that if a male is infertile, to know if the person is azoospermic, oligospermic, and also what is the type of azoospermia. If the azoospermia is obstructive or it is non-obstructive. In case, so overall, one of the commonest cause of male infertility is a chromosomal disorder known as Klinefelter syndrome. In Klinefelter syndrome, there is an extra X chromosome. Normally, a male has an X and a Y. So, in Klinefelter syndrome, due to non disjunction of the X's, there is XXY. So, there's an additional X chromosome which causes primary infertility, mild intellectual problems, as well as there is gynecomastia and certain other features which we are aware of. So, Klinefelter syndrome should be thought of when you have a male with infertility. It is not very difficult to look at a male and be sure that, okay, I'm sure this person does not have Klinefelter syndrome. Once you've seen the person and you know the person does not have Klinefelter syndrome and you've done a semen analysis, now you look at non-obstructive versus obstructive azoospermia. When you are thinking of an obstructive azoospermia, the clue in the semen analysis will be absent of fructose that will be present. The commonest genetic cause for obstructive azoospermia is congenital absence of vas deferens. So this is part of a genetic syndrome known as cystic fibrosis. So, when we have obstructive azoospermia, we test for cystic fibrosis, and this test is now easily available. It's an NGS based test which will be done on the blood of the male partner. Now we can come on to non-obstructive azoospermia. When you have a non-obstructive azoospermia, you do a karyotype. In the karyotype, you will find out Klinefelter or not. And the second test you do here is Y chromosome microdeletion. So a Y chromosome has certain areas AZFA, AZFB, and AZFC, that is azoospermic factor A, B, and C. If any of these are deleted, the spermatogenesis potential of this male will be lower. So now this test is known as MLPA or a PCR test. So on this PCR test, we can find the deletions of the Y chromosomes. So male infertility, this is the basic that we can remember.
Thank you so much for clarifying it. Like you made it crystal clear. So yeah, uh, this y chromosome micro deletion we are targeting to do in those azoospermic males, where we are thinking of doing TISA and getting testicular sperm. So since it is genetic, and Veronica, can you tell me, does it go as a Mendelian ADA or AR way, or it follows some other kind of genetic thing? But it gets transmitted to the offspring,
Yes,
isn't it?
yes,
And if it is positive, then you should counsel the patient and couple about transmitting the same disease to their progeny, and that could be deleterious. And it many a times we, the infertility specialists, we understand that even if we are telling them no, 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 please don't do, it is going to be harmful for your child, and they'll say let it be madam, please abhi kar do, हमें अपना
yes,
ही स्पर्म चाहिए. तो
yes, yes.
and
Which
that
is great, because who knows what will happen when the that child becomes 40 years. We can't, not let that child be born only because he may be infertile.
exactly, exactly.
Yes,
That is the ethical and emotional aspect. And apart from that, the guidelines, they used to say that if it is positive, you should at least give them a proper genetic counseling. Here comes my next question. Now, as per ART Act 2021, we have got the need of mental health counselor, as well as genetic counseling has become really, really prevalent. And good thing is all these genetic labs, they are coming forward, and they always, whenever they are calling to send the test, they'll tell us that madam, we have our own genetic counselor, and he or she can do it for you online, offline, as you want to. That brings our another question, and a debate going on, Europeans versus Americans. Does Is PGTA mandatory for every female above 38, 39, or it should be optional, or a choice made by the couple along with their reproductive medicine specialist? Looking at the fewer number of eggs we are going to get, the quantity of the number of blastocysts or embryos we are going to make, and sending them for testing, and when it is not very clear that this particular embryo which is being tested, even if it is negative, it is going to be absolutely fine. What is your view, Dr. Veronica, regarding universal PGTA, whether it is invasive or non invasive? That we'll ask you later. What is your opinion? Should we use it as a blanket, or it should be counseling based and as per the choice of the couple?
thank you, ma'am. It's a very interesting question. But before this, I would like to answer your previous question, which was about Y chromosomal microdeletion. So, Y chromosomal microdeletion, of course, is present on the Y chromosome, and this inheritance is known as Y linked inheritance. So, this is different from the dominant, recessive, X
Yes,
linked.
yes, that's what
This
I
is,
wasn't able to explain. Thank you.
yes,
Please.
yes,
Yeah.
ma'am. So it's called Y linked. So it's interesting. So Y will definitely Y एक लड़के से एक लड़के में ही जाएगा. So that
Yes,
means
yes,
Y will not go from a man to a girl, right?
yes, yes,
So
yes, that's
यस, एक मेल जो हमारे पास आता है जो इनफर्टाइल है, उसके सारे लड़के who have will have that micro deletion, and they all will have the same disorder as the male, but none of the girls will be infertile. So when we want to in there are three micro deletion, A, Z, F, A, B or C. A और B micro deletion जिन मेल्स में होती है, all of these males are completely infertile, but in the category C there are some males who are subfertile, and that's why we have this uh, conversation of it going to their next generation. So
and
that
we
is one.
Yeah, and we keep witnessing. I know at least 10 families where the whole family, three, four brothers, they all are azoospermic or infertile.
Yeah.
Yes. My next question, Veronica.
Yes. So I think that question definitely you all will answer better. If IVF should be done for all, I think nothing should
No,
be a.
no, no, no.
You mean
It's not.
PGTA? No, ma'am, PGTA. Yeah, that's what I was answering. So the next question was if IVF with PGTA should be done for all females with an advanced maternal age. If left to me, I think it is a great idea because their number of chances to have a healthy baby are much lesser. So why not already test and give them a best chance? So that is what I think is true. Europe is always more conservative in its approach, but I'd love to hear the opinion of everyone.
So
Especially
I
in
would.
this era of single embryo transfer, we are aiming at many clinics, even at the age of 35, 34. At least they are offering PGTA to everyone, and they are just transferring euploid embryos to increase the chances of conception. Yes, Archie.
So we need to understand right over here that Indian female is lagging behind European. Some 15 years difference is there. So the number of eggs in 38 years lady in European context to the one in Indian, there will be a lot of difference. So in Europe, you can put everybody for 38, you can go for this test. But in Indian scenario where POI is so common, how to get so many number of eggs and go for this testing for each and everybody, you cannot make it compulsory. It can be only be done where you have good number of blastocysts, then only you can think about it. Where the day 3 is difficult, the number is less, how can it be customized to all? It cannot be. Maybe in Europe, yes, but in Indian situation, no.
See,
It can be like it can be according to fertility
So,
consultant what the
Dr. Raj
outcome they get.
and Anu are
I
saying
have
something.
one point also that in India, we have to see the cost factor also. See,
absolutely.
the embryo biopsy, PGT, and all is not cheap. Okay, so we should probably judiciously use it only in certain cases where it is really required. You cannot give PGTA for all, beyond a certain age. What is your take on that, Veronica? Dr. Veronica?
No, definitely. It is only beyond a certain age that the chances of aneuploidy steeply increase. So it is after that 39 years of age when we have a very steep increase and more than a 5% chance of having an aneuploid fetus. So after that age, I think offering is a good idea. But of course, making compulsory, we are not there yet in India. Yes.
Yes, Raj, do
So
you want to add?
basically, my take on this is actually a combination of everything. I think we have to individualize and not give it as a blanket, purely because after getting the couple to spend so much on on like a high-end test like PGTA, if you have no normal embryos to transfer, or if you have embryos with low mosaicism to transfer, then what is your take? Are you going to get them to go through a cycle with nothing in hand, or are you going to take the risk of transferring a low mosaic, which might actually end up becoming like a embryo with a problem? So that has to be individualized. I completely agree with Archie. Age becomes a big problem whenever you see a good cohort. Now at 38, if I end up getting 7, 8 embryos, I am going to be tempted to offer. If I have 1 or 2 embryos, then if it's not a good embryo, it is not going to implant anyway. Then why put her through a PGTA?
So let me be the devil's advocate here. At the age of 39, in this era, when we are having non invasive PGTA testing first, you just have to send that blastocyst culture fluid. And tests are not as expensive as carrying an abnormal fetus till 3 months, 4 months, or 5 months, and being asked to abort, that is emotionally, financially draining every way. First thing. Second thing, if a couple who is not opting for a donor cycle and they want their own egg even at 41 and 40, giving them this test, even if you have to do oocyte pooling and make multiple embryos and create that pool, and you need one blasto good blastocyst to make her pregnant, is a better idea than just doing it otherwise. And we have all witnessed that all those beautiful embryos going on 6A blast, and then 10 triple line blood flow zone 4, you transfer and they don't conceive. So why, when there is a steep rise, 40, 41 is the age where, if we are offering them, and nobody can, any guideline line can never make it mandatory to undergo any such kind of test. By mandatory here we mean that we must at least offer,
Offer.
otherwise
Yes.
this patient or this couple goes to some other doctor, and that person is being advised to do the same, and that couple can think that my doctor didn't knew about it. That is also a way of thinking. So that is different thing. Veronica can tell us what is her opinion regarding sending a couple for IVF with PGTA versus trying naturally in cases of recurrent pregnancy loss, and waiting for a normal conception to take place, especially in cases of Robertsonian translocation and other those kind of illnesses which are already tested, and couple has to be advised.
So in couples with recurrent pregnancy losses, of course, first thing is we need to find a cause. Once we've ruled out a uterine cause and the APLA profile and the ANA profile, and we've done a couple karyotype, if all this is normal, then sometimes we go and do the immunological testing as well. So, if we have a Robertsonian or a reciprocal translocation in the couple, the chance of having it again is very high. It is almost up to 40 to 50%. In such a case, IVF with PGT-SR, that is IVF for structural rearrangement, is a great thing and a great technology available, because such couples are really in distress. But if we do not have a translocation, offering a IVF in couples with good fertility, with recurrent pregnancy loss, has, of course, the benefits are have not been proven for such couples, and they may try naturally as well, because the etiology for recurrent pregnancy loss in a couple with a normal karyotype, we are not very sure. It is maybe the uterine microenvironment or the uterine milieu which is not working.
So, Veronica, it's about a couple of mine, and the husband had a balanced translocation. They were hetero, wife was normal, and they went for genetic counseling. And there they were told that they still have only 25% chances of getting this in their next offspring. And you won't believe, they underwent 8 or 9 pregnancies, out of which they had two daughters. And they decided to wait, because, so here comes the question, what is this genetic counseling, what do you do, and how do you do it?
So, genetic counseling is a process of telling the individual, a couple, a child, anyone about the risk of them and their offsprings and the family members having any genetic disorder. It is typically and ideally performed by a geneticist, that is, a medical geneticist who's a doctor. To support us, we have genetic counselors who are maybe BScs, MScs. But the issue now is there are, because there are not enough maybe geneticists, genetic counseling is being performed right, left, center by lots of people who are not really trained. So that's why the thing you mentioned, the 25% recurrent risk is, we know, for autosomal recessive disorder. and for a translocation that like this, the risk is almost 50%. So a correct genetic counseling is extremely important, and we have to understand and tell the couple that we have to need to understand their problems, their financial constraints, and their body. And it's best if we can also understand that how much they are going to go through in the next few years if we let them try naturally in a disorder with 50% recurrence rate. There are so many women, I'm sure we all know, who go under depression in such cases. And IVF with PGT-SR is great, and it will give a sure shot chance of having a normal child. And of course, the caveat here is we need to test again with amniocentesis at 16 weeks. We need to be sure because of the mosaicism.
That's a great input. Dr. Anu, do you want to ask something?
You're mute.
Ma'am, you're mute.
Yeah. So, see, there is one is disorders of, reproduction. Like one is the disorders of sexual development, which also have a genetic basis. So,
Yes.
how frequently you see those sexual development problems in your day-to-day practice?
Okay.
Like I'm
So I
talking
think now we
about,
can come on to female infertility. So most of the disorders of sexual development when we come across are in females with certain amenorrheas. They most commonly present with primary amenorrheas and also infertility. So disorders of sexual development can be classified on the basis of a defect at the level of the gonad, a defect at the level of the hormones, or a defect externally. So, DSDs are a group of disorders where there is a difference or a discordance between the phenotypic sex and the genotypic sex. That is what DSD is. So it is actually quite common, and but I think that is one area where awareness and to come out still remains, because I think externally the children who are males will not be gotten to medical attention because the family would like them to be rearing up as males. But if externally a girl is a girl from outside and a male from inside, that is when the family would like to come to medical attention. So, in this group of disorders, there is a lot more going on than just the genetic testing. So, genetic testing for such group of disorders starts with doing a phenotypic examination, seeing the external sex, then looking at the internal sex, doing a karyotype. If a karyotype shows discordance, then we want to find out the gene which is responsible for such a defect. And to find out this gene, we will do the sequencing of all genes related to DST.
this is a very interesting field also for the doctor, to
Yes,
to
yes,
to get into the depth of these sexual development disorders, because there's a vast array of these disorders. Also, if the patient is genetically a male but outwardly a female, it also depends on that patient what they want to do, how they feel
yes,
about it, whether they want to
yes,
be raised or continue as a male only or a female. And here lies the family has to accept them like that. Supposing they are male but outwardly female, they would like to be like females only. So this,
yes,
we have to spread this social awareness regarding this. And also they should also be open to plastic surgeries for those changes, sexual changes. And I think we'll take a lot of time to reach there. Dr. Veronica, what do you say?
yes. So I think here is where lies the divide between maybe the tier 1 and the tier 3 cities. it comes with a level of education, definitely, and with a level of trying to identify that my child is suffering from a problem and this is not a stigma. So I think we will get there, but yes, this will take time.
So I just want to add a very interesting anecdote on that topic. There has been a recent trend in the US where, so now we are talking about ambiguous genitalia out here, and kids with ambiguous genitalia as young as 11 and 12 have been allowed to decide what gender they should choose. And I feel personally, I feel 11 and 12 is too young, and I just want to go, because traditionally in India you would need to be minimum 18 before you can, choose one way or the other. And parents are also advised to, wait until I'm like sure all of us have delivered a child with some ambiguity at some point of time. एक दो पेशेंट तो हो ही गए होंगे, अभी 25 साल से प्रैक्टिस कर रहे होंगे। तो जब ये होता है, हम खुद डॉक्टर्स करके पेशेंट्स को एडवाइस करते हैं कि आप रुक जाओ जब तक बच्चा 18 का नहीं हो जाए। ऑब्वियसली इफ इट्स अ टेस्टिस व्हिच इज एन एब्डोमिनल देन टेस्टिकुलर कैंसर का डर है, तो उसकी तो डिस्कशन अलग हो जाती है। बट एक्सटर्नल के लिए वी नॉर्मली आस्क देम टू वेट। Whereas अभी अमेरिका में there is a series of cases that are being done as young as 11. And I just wanted to ask the panel what their views on that is.
So, Raj, as per my understanding, the reason why are they asking to decide at that age is probably that child will adjust with that gender identity, which will take longer and more draining if he or she decides it later at the age of 18 or 20. That has become the way of life, and that will be more stigmatized, and that child will feel more bullied, and every way it will be more painful for that child to change the gender at the later age when he or she is maturer. That could be one reason why they are being asked to do it at around 11
No,
to
no,
12.
they are
Acceptability
not
is
being
high.
asked. If a child is coming forward, he is being allowed. See, a child
Yes,
at
so
11
that's
is
the
still a
reason.
minor.
So
Okay.
that's the reason why are they doing it, to get themselves well accustomed and well adjusted to that particular gender if they adopt it to at earlier age.
What do you think, Archie? What's
See,
your take on
Dr.
that?
Raj, what my take is on that, I agree with Dr. Seema. The earlier, the better, because you don't know in schools and all, it's so much peer pressure. Like you do the school as a female, and suddenly when you go to college, you become a male kind of. So it's very difficult for the person for the child to accept that change suddenly. And also there's a mind play into it. The child may be feeling like a female, and forcefully, if we don't allow her to change that at 11 or 12, they may develop psychological problems. So I think that's why they must have allowed earlier.
Archie, what do you think? Is it like
Well,
okay to allow a 11, 12-year-old to take such a
it is
huge
also
monumental
better.
decision this early?
I too feel that the younger the better, because the child will have better adjustment with himself or herself than to be grown up, because he or she will be bullied a lot. And definitely European countries have more thoughts for these things. They are developed already, and they're already the basis that studies are there. They have, and they must have analyzed all these things, because in our country things are running late. We are still in the developing phase. So definitely I think the younger the better, because in
Veronica,
adults.
what's your take on it?
Dr. Veronica.
Hi, ma'am. Can you please repeat the question? Thank
Okay,
you.
so there have been instances in America where a child as young as 11 has
Okay,
been
okay. I
allowed
got it.
to,
I got it.
yeah.
Yes, yes.
So, so I mean, what is your take? Is an 11-year-old mature enough to decide what final sex they want to be? That's my question.
I think here I agree with Seema ma'am that the adolescence is a period that they need to grow up as someone they will be throughout their adulthood. And as we see, or as the children we see, even if we have young girls or boys coming at 5 or 6 years of age, and if the parents are supportive, they know if they are a boy or the girl or a girl. They even speak like that, and in that gender specific manner. So, if we can actually start giving hormones or do surgeries or perform counseling at a younger age of about 11, 12 years, it will make them more stable individuals at the age of 18 years.
Okay. I just thought it was
Ma'am,
very
I cannot
interesting
hear.
because
Yes, yes.
we don't grant any other decision making to a 11-year
Well,
old,
Yes.
are
and here
already
suddenly a
40
11
minutes.
year
Yeah,
are we? Oh,
this is a non-ending kind of discussion. One more factor, genetic condition, which we have not discussed in female infertility, Dr. Veronica, is Turner syndrome.
yes.
And that is a kind of very eluding thing. They present with subfertility, they present with obstetric complications, and so on and so forth. So how frequent turners are in your OPD, as you are one of the biggest referral centers of India?
So I think we haven't discussed much of female infertility as
Yes,
well.
please.
So,
Huh.
so female infertility, of course, the commonest cause of premature ovarian failure or premature or season menstruation or primary amenorrhea is Turner syndrome. Turner syndrome means that out of the two X chromosomes that should be present in a female, one is missing. Also, there could be both of them could be present, but there could be a different or a wrong orientation of one of the chromosomes. There could be deletion of a part of the chromosome. Also, there could be a mosaicism. That means there could be two cell lines, one having 45XO, that is uh, decrease in the number of X chromosome, and one having 45XY. So, when we have Turner syndrome associated with a Y chromosome also present in a girl, that should make us aware and alert us that we need to remove that gonad of that girl, because there is a higher chance of having gonadoblastoma. So, girls who are a little bit short in height, intellect is okay, never too intelligent, 50% have deafness, present with primary amenorrhea. The first test, the easiest test, we can do two tests. Number one is fish test will give you the report in 2 to 3 days. It will cost a little more than karyotype, and the karyotype will give you a report in 3 weeks because the cells needs to be cultured. And we have good treatment for Turner syndrome if diagnosed early. So, if your girl is not increasing in height as compared to her peers, and if people in your house have a modestly good height, it is useful to talk to your pediatrician and obstetrician about the same, so that we can test in time and also start growth hormone supplementation for such girls. Growth hormone is approved indication for Turner syndrome, and it has to be started as early as possible so that these girls reach their height potential. Later, of course, we give them HRT as well. So that is the commonest cause of primary amenorrhea and later infertility. Another condition that we must look for in women who come with POI is Fragile X syndrome associated POI, known as FXPOI. So, if you have a lady who comes with premature ovarian failure, you ask her family history, which is extremely important for all genetic disorder. If her mother also had premature ovarian insufficiency, and her grandmother also, and some males in the family have intellectual disability, so this is a very specific pedigree for Fragile X syndrome. So this causes Fragile X POI. So in a family with multiple females having POI and males having intellectual disability, we should think of Fragile X syndrome. Then the third and the final category of disorders of female infertility are single gene disorders. Single gene disorders means that there is a mutation in the genes at the level of hypothalamus, at the level of FSH receptor, LH receptor, in the gonads, in any of our HPO axis. So any gene which controls the function of these hormones can cause primary infertility, and the test we can do for this is a exome sequencing. So these three categories we need to remember.
So that was an excellent take on. Before we start with the shots, I would like to tell our doctors about non-invasive PG and TA, non-invasive genetic testing, Dr. Veronica, and what is the how is it difference, and what should we expect the difference in result between invasive and non-invasive PGTA.
So, invasive PGT, I think we all know what we do. In non invasive, we take the media and we test our aneuploidy related tests on on that media that is present. Of course, there are now lots of discussion about the concordance that is present between the invasive and the non invasive PGTA, but till now I know that the results, though have been good, have not been 100%. The concordance has not been 100%, but that is definitely a future, and a future not more than maybe 2 or 3 years away.
So it is just like NIPT versus amniocentesis. We used to have a decade back. Now we are on invasive versus non-invasive. Before we end up, and I ask for those three shots from our guests, there is a question for Dr. Veronica from Mr. Arvind Pandey. क्या होता है हार्ट बीट तेज होने से क्या पता चलता है? It seems he's been told it has some genetic association.
Yes. Okay, so a lot of times a fetal tachycardia is noted. The commonest cause of fetal tachycardia is maternal tachycardia. So, if the mother is stressed at the time, or the mother has just come from walking a lot, so there can be tachycardia. Maybe we have to repeat the echo, and you can also do an ECG of the mother. There are some genetic conditions also which are associated with fetal tachycardia, and for these conditions, it is important that you do a very good detailed fetal echocardiography. In that, we will also understand if there are any rhythm abnormalities or structural abnormalities related to this, and from that, your doctor can guide you.
Dr. Veronica, that fetal echocardiography can be properly done, obviously 22 weeks later. But if it is first trimester tachycardia, I think this person is meant to ask. So, is there any association with any kind of genetic anomaly?
Genetic, yes. So it has also been known that if there is tachycardia, it is more commonly associated with certain aneuploidies. So these aneuploidies, we need to then look at the ductus venosus, look at the tricuspid regurgitation, and it's best that instead of doing the weaker screening test, you can directly do a non-invasive prenatal screening in the first trimester in the first trimester tachycardias.
So, thank you, Dr. Veronica. The custom of this show is that before end, Anu, you want to say something? Please,
No, no,
please.
no. I want to
So,
start the shots.
okay. So, I wanted to ask my guest, be ready with your three things regarding genetics and infertility, Veronica. By the time Dr. Anuradha Khar, she wants to take those shots first.
Yes.
Veronica, Veronica, shots are like three important points out of all
Okay.
this what we have discussed.
Yes.
Okay, I start with male infertility because I asked that question that about azoospermia. We see that very commonly. We have to differentiate obstructive versus non-obstructive. Number one. Second, if it is non-obstructive, look for chromosomal Y deletion in chromosomes. And third is that counseling plays a very important part. We have to tell them that if you have a girl, she will escape this Y deletion, and it will be transmitted to the males, and the males will have a similar problem. Number two, the role of geneticists in the hospital, genetic counseling in the hospital, and we have to counsel the advanced age group who want to be mothers, the recurrent pregnancy loss patients, and recurrent implantation failures. Those are my important shots for today. Thank you.
Thank you. Thank you,
Thank
Veronica.
you, Veronica. Now it's your turn for those shots.
Thank you. So it was great being here. So one important thing is that genetic disorders are not straightforward and simple. Whenever faced with one, always have a discussion with your geneticist, and you should think genetic. When we think it, we can definitely get the answers. And one of the commonest causes of female infertility is Turner syndrome. Do a karyotype for that. The second common, as we spoke, is Fragile X POI. The test is different. That is a triplet repeat PCR, and then we do exome sequencing. Similarly, for males, once you've done a karyotype for Klinefelters and you've done a MLPA for Y chromosome microdeletion for cystic fibrosis, when there is an obstructive azoospermia, go ahead and do an exome sequencing.
Thank you so much. So, Dr. Raj Lakshmi Walavalkar,
You
you're
are
muted.
muted, Raj.
So my three shots are going to be: if you're young and your ovarian reserve has drastically gone down, please get a genetic testing done if your doctor asks you to do so. My second shot for the day is: if you do not have any other medical problem and you tend to have a very poor sperm reserve, you have severe oaths, which is oligoactinoteratospermia, and you are recommended to go in for genetic testing. If you have azoospermia, please get those testings done. And three, the third shot is for all my colleagues. Have one best friend who is a geneticist who will be at the end of a phone call, the way the four of us can call Veronica.
Yes, I do. I
So
keep
yes.
doing that.
Thank you.
Yeah. So, Dr. Arshi,
So my take home is, in India, it is a common thought that males never age. So this is a myth. Males do age, and they are very important. And all these genetic factors does affect the sperm a lot. So people are more like males never age. So definitely don't waste your age. If the male is a 40 plus or 35 plus, definitely the syndromes can be there, the defects can be there. So definitely age, both male and female should have their babies in early age. And syndromes do occur in early age. It is not like 35 plus only you should go for genetic counseling. Nowadays it should be made mandatory for each and every patient. All the obstetricians should at least counsel their patient regarding genetic anomalies which can be the possibility, and they should make a habit of referring the patient to a geneticist. Definitely it is a must with to be done in future era. Secondly, uh, most of the things have been covered. Yeah, you want
I
to
have
add?
one question to Veronica, one last bit before Seema's shots. Veronica, we are in, metros. Okay, it's very easy for us to find a geneticist and refer off the patient for a counseling. What about the smaller towns, districts where there is no concept of a genetic clinic, geneticist, or a counselor? Uh, is there any portal where they can take online consultations for their patients? Yeah,
he
the
also
patient.
does.
Yes.
Yeah, no, that's what I see. This is
Yes.
this our this talk show is not only about what doctors should do, what patients can also do, and what the
Yes.
patient and doctor together can sit and
So
have a
many
genetic.
times the patients themselves, take an appointment here.
Yeah, we should use technology where we cannot reach with our specialists. So, what
Yes.
is, do you do these counselings
Yes.
online?
maximum now, yes, I think a lot of geneticists are doing online consults, and actually, because you're just having a conversation, and at least in the reproductive genetics, we're not examining, so it's a great idea, and it saves so much money for them also to not travel to us, and we can also get the testing collected from their centers. So
Yes.
yes, now that is possible. Yeah.
सो
Thank you very
अब
much.
मैं अपने हिंदी भाषी दर्शकों को बता दूं कि आज हमारे साथ एक हम V4 के अलावा एक बहुत बड़ी एक्सपर्ट जेनेटिक्स की एक जेनेटिसिस्ट जो अपने आप में एक ऑब्स्टेट्रिशियन एंड गायनेकोलॉजिस्ट भी हैं हमारी तरह हमारे बीच थी और उनके साथ हमने डिस्कस किया कि जो आप में से जो लोगों को निसंतानता या इनफर्टिलिटी है उनके कारण जेनेटिक हो सकते हैं वो सारे कपल्स जहाँ पर डॉक्टर आपको बोलते हैं कि आप में कोई कमी नहीं है वहाँ पे जेनेटिक बीमारियां जेनेटिक सिंड्रोम जेनेटिक कारण ज्यादा प्ले रोल करते हैं और इन सब के बारे में अगर थोड़ा ध्यान से देखा जाए तो आप अपने बचपन से अपने बच्चे की ग्रोथ में उसको पा सकते हैं जैसा डॉक्टर वेरोनिका मैम ने बताया कि अगर आपके बच्चे की हाइट स्पेशली बेटी की हाइट ज्यादा नहीं बढ़ रही है आप सब लोग की हाइट ठीक है तो आपको एक बार अपने डॉक्टर से सलाह लेना चाहिए हो सकता है कि उसको कोई जेनेटिक बीमारी टर्नर सिंड्रोम नाम की बीमारी से वो पीड़ित ना हो जिसके बहुत सारे अलग अलग वेरिएंट होते हैं और उन सारे वेरिएंट्स में कुछ वेरिएंट आगे चल के खतरा पैदा करते हैं उसी प्रकार वो लड़कियां और ये लड़कियां अक्सर उनकी हाइट कम होती है और आगे चल के जब उनको पीरियड आने का टाइम आता है तो उनको टाइम पे अपनी दोस्तों के साथ या आपकी बड़ी बेटी की तरह उसको पीरियड नहीं आता है तो जब उसकी उम्र ऐसा लगता है कि हाइट भी कम है और आजकल पीरियड बच्चों को 12 साल की उम्र तक आ जा रहा है हमने कट ऑफ 15 रखा हुआ है लेकिन अगर ये दोनों चीजें आपस में मिली हुई हैं तो आप उनको डॉक्टर के पास अगर पहले ले जाते हैं तो ना ही उसकी बीमारी सिर्फ नहीं पता चलेगी उसके साथ साथ जैसा कि आप में से बहुत सारे लोग मुझसे अक्सर हाइट बढ़ाने के नुस्खे पूछा करते हैं तो ये ग्रोथ हार्मोन का इंजेक्शन इस बच्चे पे जिसको टर्नर सिंड्रोम है उस पे ज्यादा अच्छा काम करेगा और उसके लिए वो बहुत बेहतरीन साबित होगा इसी तरह से आपका बच्चा अगर उसके में कुछ भी ऐसा लड़के में एबनॉर्मेलिटी दिखाई पड़ रही है और जैसा कल हम डिस्कस कर रहे थे कि यंग एज में अगर लड़के अपना एक सीमेन एनालिसिस करा लेते हैं उसमें एजोस्पर्मिया मिलती है तो बहुत सारी जेनेटिक बीमारियां उनका कारण हो सकती हैं और उनका हम समय पे समाधान या काउंसलिंग कर लेते हैं तो आगे चल करके हमको बहुत ज्यादा परेशान होने की जरूरत नहीं होती है इसी प्रकार से वो कपल्स जिनकी शादियां लेट हो रही हैं या जिन्होंने किसी भी कारण से बच्चा लेट पैदा करने की कोशिश कर रहे हैं एक जेनेटिक काउंसलिंग सेशन उनका लेना बनता है और आजकल अधिकतर आईवीएफ क्लिनिक्स वो जेनेटिक काउंसलिंग सेशन उनको प्रोवाइड करती हैं और वहां पे आप ये अपने जेनेटिसिस्ट और अपने रिप्रोडक्टिव मेडिसिन स्पेशलिस्ट के साथ बैठ करके अपने जो आपका गर्भ बनने जा रहा है एम्ब्रियो बनने जा रहा है उसको आपके अंदर इम्प्लांटेशन करने के पहले उसकी कुछ जेनेटिक टेस्टिंग करने की बारे में जान सकते हैं और अगर आप अफोर्ड कर सकते हैं आजकल वो बहुत ज्यादा एक्सपेंसिव भी नहीं है लगभग 8 से 10 हजार पर एम्ब्रियो ये नॉन इन्वेजिव जेनेटिक टेस्टिंग पड़ती है वो आप आराम से करा सकते हैं और उसके लिए सलाह ले सकते हैं बहुत सारे लोग पीजीटीए जो पहले जमाने में आज मतलब वो अभी भी होता है एम्ब्रियो की बायोप्सी लेके जरूरी नहीं है कि वो टेस्ट आपको कराने की जरूरत हो तो आप ऐसा बिल्कुल भी ना सोचें और आप अपने जेनेटिसिस्ट से बात करें अपने रिप्रोडक्टिव मेडिसिन स्पेशलिस्ट से बात करें और जेनेटिक काउंसलिंग कराना और आपको स्पेशली अगर बार बार गर्भपात हो रहा है तो अपने उस बच्चे का जो मिसकैरिड हुआ है अगर उसकी आप जेनेटिक टेस्टिंग कराते हैं वो नॉर्मल या एबनॉर्मल निकलता है उससे हमको बहुत सारी चीजें आपके बारे में पता करने की जरूरत पड़ती है दोस्तों ये सारी बातें आज आप लोगों ने जानी आपको पता है कि मेरे पास जेनेटिसिस्ट रेगुलर जेनेटिक क्लिनिक भी है, और मैं डॉक्टर वेरोनिका मैम को भी अक्सर परेशान किया करती हूँ, और आप लोग को ऑनलाइन कंसल्टेशन की भी उनसे सलाह दिया करती हूँ। डॉक्टर वेरोनिका ने तो मेरे 2-3 पेशेंट का सैंपल भी वहाँ से कलेक्ट करा के मंगा लिया है। थैंक यू सो मच फॉर दैट। और अगर ऐसी कोई भी प्रॉब्लम आती है, तो जैसा डॉक्टर अनुराधा मैम ने कहा कि आप डायरेक्टली आप उनसे अपने किसी भी जेनेटिसिस्ट से अपॉइंटमेंट लेकर के जा सकते हैं। कोई पूछ रहा है मैम आर्टिफिशियल इंटेलिजेंस से जेनेटिक्स में क्या क्या फायदा हो सकता है? इट्स एन एक्सलेंट क्वेश्चन वेरोनिका। बिफोर वी लीव, आई थिंक वी शुड आंसर दिस वन।
Okay, thank you for the question. So, artificial intelligence is used in multiple levels in genetics. I will just give you one example. So, genetics में हम जो बच्चे जो थोड़े डिफरेंट दिखते हैं, या फिर उनका फेशियल एक्सप्रेशन अलग है, बनावट फेस की अलग है, जिसको डिसमॉर्फिज्म बोलते हैं, जो ये डिसमॉर्फिक बच्चे होते हैं, उनको देख के ही डायग्नोसिस बना सकते हैं. फॉर एग्जाम्पल, डाउन सिंड्रोम, वी नो देयर इज एन अप स्लांट, देयर इज अ डिप्रेस्ड नेजल ब्रिज. So there is an application, an AI app called Face to Gene. इस ऐप में अगर हम फोटो डालते हैं तो वो हमको टॉप 5 आंसर्स देता है कि ये प्रॉब्लम हो सकती है. So now Down syndrome is easy for us to identify, but there are some 50,000 genetic disorders, and of course we cannot know all of them. So AI के द्वारा हमको diagnostic help बहुत मिलती है.
दैट्स ग्रेट। तो आज के लिए इतना ही। थैंक यू आवर एक्सपर्ट डॉक्टर वेरोनिका अरोरा, माय फ्रेंड्स डॉक्टर अनुराधा खार, डॉक्टर अर्शी इकबाल, डॉक्टर राजलक्ष्मी वालावलकर। कल दोस्तों सेम टाइम पे हम दोबारा मिल रहे हैं एक और इंटरेस्टिंग टॉपिक के साथ, दैट इज इम्यूनोलॉजी इन इनफर्टिलिटी। तो please log in, don't miss the session, and it is going to be as interesting as it is today. So thank you for giving all that love which you keep pouring on, and keep asking the questions so that we can try to improve ourselves. And Dr. Veronica, I cannot thank you enough. You have just taken, I just gave you few hours, I did not even tell you what am I going to ask. And thanks a lot, bacha. सॉरी, बच्चा कहने की आदत है. लोड्स ऑफ लव एंड हग्स.
Thank you.
एंड
Thank you,
दोस्तों,
Dr. Veronica.
Thank you,
Thank you,
Vipul.
Dr.
It was a
Seema,
Thank you,
pleasure.
for
doctor.
creating. Thank
Thank you,
you,
Dr.
Dr. Seema, for
Veronica. Thank you,
creating such a
everyone.
beautiful platform. Thank you, Arshi. Thank you, Raj. Now I'll do my vote appeal. Dr. Seema Pandey is going for the post of honorary librarian of ISAR. And I, Dr. Anuradha Kar, I'm going for the post of member managing committee for ISAR 24 elections. The voting starts tomorrow, 11 January, 10 a.m. onwards. You'll get your voting links, and kindly consider us for your valuable vote and support. Thank you.
Veronica, highest viewership as of now. Doctors, few who have missed, they are asking how can we get the full session. So see, like we don't need to advertise it for long time. Your presence is enough.
Thank you. Thank you so much, ma'am. Thanks.
Thank you.
For this, I'm going to, for my doctors and for our viewers, this is going to be, this show will be directly, it is being recorded. It will be played on Facebook and LinkedIn
It
and
is
everywhere.
already.
Yeah, it will be there. So you can watch it anytime if you have missed it because of your busy schedule. And you can get in touch with any of us for your further questions. We are there for you. Thank you.
Thank you. Good night, Shabakat.
Good
Take
night.
very
Good
good
night.
care of yourselves. We are shining off. Bye bye.